Hello friends, and welcome to Science Knowledge Base. If you haven't already done so, click the subscribe button and the bell icon so you know every time I upload a new video. If you want me to go over any particular science topic, write it in the comment section below. Today we are talking about kidney failure, so let's jump right in. Before I speak about reduction in renal function, I'm going to tell you about some important mechanisms of the kidney. Figure 1 shows a very simple illustration of a nephron. At each nephron, the kidney filters out red blood cells and large proteins, and hydrostatic pressure pushes the fluid and solute through a membrane passively. The membrane has 3 layers: a fenestrated endothelium, which only lets through blood components other than blood cells, a negatively charged basement membrane, which prevents proteins from passing through, and foot processes of podocytes of the glomerulus that allow for selective reabsorption to happen. The capillary forces determine how much solute goes across the basement membrane. The main filtration force is the hydrostatic pressure from the glomerular capillaries, which is normally 55 millimeters of mercury. The other filtration force is the capsular space colloid osmotic pressure, and this is 0 because proteins are not present in the capsular space. So the main functions of the kidney are filtration, reabsorption, secretion, and excretion. So, in simple words, a reduction in renal function is where kidneys completely do not, or have reduced capacity to excrete waste products and regulate volume and composition of body fluid. Let's quickly crash course the kidney to set everything into context. Figure 2 shows a bit more of a detailed illustration of the nephron. We are going to start at the proximal convoluted tubule, which is where reabsorption takes place. Here, all the glucose and amino acids, 65% of sodium and water get reabsorbed. Sodium gets reabsorbed by primary active transport via a sodium-potassium pump. Glucose, amino acids, and vitamins get reabsorbed through secondary active transport via sodium electrochemical gradients that drive passive paracellular diffusion. Water gets reabsorbed by osmosis driven by solute reabsorption, and lipid-soluble solutes also get reabsorbed via passive diffusion driven by the concentration gradient created by the reabsorption of water. The non-absorbed solutes then go on to the loop of Henle, which is here. This is the descending limb, and this is the ascending limb. The descending limb reabsorbs water via osmosis. Solutes do not get reabsorbed here. And in the ascending limb, sodium passively moves down a concentration gradient, and sodium, potassium, and chloride get reabsorbed through a symporter. Sodium-potassium ATPase has the symporter function, and it does this by creating an ionic gradient. Calcium and magnesium also get reabsorbed in the ascending limb via passive paracellular diffusion driven by an electrochemical gradient, and no water gets reabsorbed here. Moving on to the distal convoluted tubule, here there is primary active transport of sodium at the basolateral membrane and secondary active transport at the apical membrane through sodium chloride symporters and channels. This process is regulated by a hormone called aldosterone. Parathyroid hormone, or PTH, also causes passive calcium reabsorption, and this continues in the collecting duct. Something I haven't mentioned about is tubular secretion, which occurs to dispose of substances such as urea and uric acid. Excess potassium also gets eliminated via aldosterone at the collecting duct and the distal convoluted tubule. Hydrogen ions get eliminated when blood pH drops below normal, and when blood pH increases above normal, chloride reabsorption occurs, which causes the excretion of bicarbonate ions. Creatinine, ammonia, and other organic acids also get secreted. Here in figure 3, we have the anatomy of the urinary system. So finally, urinary excretion occurs where the urine travels to the ureter, gets stored in the bladder, and then gets excreted from the body. So what is the difference between renal impairment and renal failure? Both of these terms are used interchangeably sometimes, but they are actually a bit different. Renal impairment is less severe than renal failure, and it does not cause reduction in renal function that produces high levels of urea and creatinine in the blood, whereas renal failure does. There are 3 types of renal failure: acute renal failure, chronic renal failure, and acute-on-chronic renal failure. Starting with acute, in this the body has little time to adapt to rapid deterioration of renal function. The kidneys would previously be normal and it affects them over a short period of time. This can be hours or days or weeks. Acute renal failure may present no symptoms other than those of the underlying cause. It is detected by rising serum creatinine, and it causes loss of fluid volume regulation and reduced capacity of excretion of the kidney. Rapid retention of fluid leads to pulmonary oedema. Retention of potassium leads to high potassium levels in the blood, and retention of hydrogen ions leads to acidosis. And all of these conditions can be life-threatening if they are immediately not treated. Here, figure 4 shows some causes of acute renal failure, which you can look at in your own time. Moving on to chronic renal failure, this is kidney damage over a long period of time. It is not reversible, and it can result from acute renal failure. Here the body has longer to adapt to reduction in renal function, and there may be compensatory physiological and pathophysiological adaptations. It slowly progresses towards end-stage renal failure, for which renal replacement therapy or transplant becomes important. The rate of progression is variable, and there are methods to slow down reduction in renal function, including treatment of underlying conditions, control of blood pressure, and reduction of proteinuria. The rate of progression to end stage can also be predicted by plotting a reciprocal of creatinine against time. Figure 5 shows various symptoms of chronic renal failure. These can vary as they are most likely related to underlying conditions that the patient already had. Acute-on-chronic renal failure is when there is a sharp rate in decline of renal function when a patient is already suffering from chronic renal failure. The acute part may be unrelated to the chronic, and acute-on-chronic renal failure may be caused by the underlying condition or disease becoming worse. Chronic kidney disease is caused by conditions that put a strain on the kidneys. These can include high blood pressure, which is self-explanatory, diabetes, in which too much glucose damages the filtering mechanisms of the kidney, high cholesterol, where the buildup of fatty deposits in blood vessels supplying the kidneys gives them lack of oxygen for active processes, kidney infections, again self-explanatory, glomerulonephritis, which causes kidney inflammation, polycystic kidney disease, which is an inherited condition where cysts develop in the kidneys, blockages in the flow of urine, such as in reoccurring kidney stones or an enlarged prostate, and long-term use of certain medicines, such as non-steroidal anti-inflammatory drugs. Causes of acute renal failure can be a wide number of things, and it is very rare that the kidney itself is the problem. To reflect this, causes are normally grouped as pre-renal, renal, and post-renal causes. Pre-renal causes include dehydration, circulatory shock, obstructed blood supply, and certain drugs such as cyclosporin. Renal causes include glomerulonephritis, acute tubular necrosis, drugs such as penicillin, toxins, hypertension, and preeclampsia. And post-renal causes include situations such as urethral obstruction and ureteric obstruction. Now we move on to what happens as a result of the kidneys not working properly. Reduction in capacity of the kidneys in excreting waste products leads to the retention of those waste products in the body. The swelling of the kidney can occur due to urine buildup, which is known as hydronephrosis. This can occur in one or both kidneys and occurs due to a blockage or obstruction not allowing urine to drain. Causes can include kidney stones, congenital blockage, which is a defect present at birth, a blood clot, tissue scarring, a tumour or cancer, a benign enlarged prostate, pregnancy, or a urinary tract infection. The rate of accumulation determines the clinical presentation and the effects of it. On the other hand, damage to glomeruli, such as in nephrotic syndrome, is one cause of the kidneys failing to control body fluid, which can lead to oedema. In this, there is low levels of protein and/or albumin in the blood and high blood pressure. Failure of the kidney to control body fluid can be caused by physical damage and/or injury to the kidney itself. And the inability to control volume of body fluid leads to the retention of fluid in circulation, peripheral tissues, and/or lungs. And the latter produces breathlessness and can be life-threatening. Since the kidneys do not retain fluid that they are supposed to, this manifests as dehydration and results in various degrees of circulatory collapse. Let's move on to how renal failure is diagnosed. There is a range of biochemistry blood tests that can help in the diagnosis of renal failure. The main one is Usinase, urea and electrolytes, which is a profile that includes sodium, potassium, creatinine, and urea. Also, proteins, urate, calcium, magnesium, albumin, glucose, chloride, and maybe alkaline phosphatase as well, can help in the diagnosis. Urinalysis can qualitatively show the presence of glucose, bilirubin, ketones, blood, proteins, urobilinogen, nitrites, and leukocytes. It also shows pH and specific gravity in urine, and all of this information can indicate what blood tests to do or confirm the results of blood tests that a patient has already had done. Albumin, creatinine, and proteins can also be measured in urine. However, the main test used to diagnose renal failure is serum creatinine, as this shows the degree of the proportion of renal function loss and is used in an equation to calculate the GFR, the glomerular filtration rate, which can also go on to indicate the percentage at which the kidney is functioning at. Figure 6 shows the sort of chart used to determine the severity of the kidney disease. Kidneys are one of the major organs in the body, so there are other effects of kidney failure as well. Kidneys not working properly can cause anemia. Reduced erythropoietin production leads to normochromic anemia, which can be disabling. Recombinant erythropoietin can be given to bring the hemoglobin levels back to normal. Severe and complex disturbances of calcium and phosphate metabolism occur in chronic renal failure. Lack of 1-hydroxylation of vitamin D leads to loss of activity and osteomalacia. Also, retention of phosphate is another complication and is corrected by patients taking off phosphate binders, which prevent absorption of dietary phosphate. pathophysiology of calcium and phosphate metabolism can also lead to hyperparathyroidism. Patients with chronic renal failure are at risk of getting atheromas and hypertension. They are also more at risk of ischemic heart disease, peripheral vascular disease, cerebrovascular disease, and heart failure. In kidney disease, the patient has secondary immunodeficiency and is more susceptible to infections such as TB and coronavirus. Skin problems also arise as a result of renal failure, and these can include impaired wound healing and pruritus. Finally, endocrine dysfunctions can also arise as a result of renal failure. Here are the references for this video. Thank you for watching. If you liked the video, don't forget to hit the like button, and I would love to hear your thoughts on it in the comment section below.